Good afternoon, doctors. So today we're going to take the review of the three last topics that will be included in the exam for next Saturday. Uh, this is the first one, just to remember what is the secondary syphilis. As we remember, we talked about this patient, Silfrido Chancras, who came to the office presenting these signs and symptoms. The first one, patchy hair loss of a sudden onset, and which has the characteristics of a patchy pattern or the appearance of moth-eaten dermatosis. He was also presenting this symmetrical macular exanthema in the part of his trunk, talking about his palms and soles of the feet. He was showing some maculopapular lesions with the scalene ring, and finally painful radial fissures around his mouth. We decided that this 4-year-old male has symptoms of secondary syphilis. We know so far that the cause of syphilis is this bacteria called Treponema pallidum, and as we know, syphilis can spread if we have the contact person to person through the skin or even mucous membrane with those small or tiny cuts or abrasions, which are called sores. And as we know, the most common route for transmission is during the sexual activity intercourse with no protection. So we must think about or suspect about this syphilis in any sexually active patient that it's presenting those genital lesions or those rashes. And as we said, avoid kissing a sore. As we knew, this syphilis can develop in different stages. We have the primary, secondary, latent, and tertiary syphilis. And of course, all these signs and symptoms can vary, but we can also be aware that these stages may overlap. And as we knew, we can have the disease and not really notice only after the years that passed. As we knew, the first sign of syphilis is a small painless sore called a chancre, and this usually will develop about 2-3 weeks after the sexual intercourse, and this sore will appear the spot where the bacteria enter to our body. Typically, it's on the genitals, but can also be presented in the rectum or the mouth. It's about 31% sensitive because most of the time it's painless, and as we said, it can be hidden within the vagina or the rectum with no pain. So it will continue growing and affecting the tissues around, and this chancre will be healing on its own in the next 3 to 6 weeks. In primary syphilis, most of the people affected will develop only one chancre, but some of them can have a couple of them. And after some weeks of this original chancre, then the person may experience a rash that it's typically starting on the trunk, and eventually it could cover the entire body. As we saw in our patient, it can also be affecting the palms of the hands and the soles of the feet. And this rash is not itchy and could be along with wart-like sores in the mouth or the genital area. The people may also experience, as our patient, hair loss, pain, specifically on a muscle axis, fever, may have a sore throat, or may also we might also find swollen lymph nodes. And as we knew, these symptoms may disappear within a few weeks or come over and over as long as 1 year. As we knew, if we don't make our diagnose on early stages, we don't take the treatment for this syphilis, then these symptoms may remain just there, or maybe they can we might have a flare, and this disease may progress to the hidden or the stage which is called the latent stage, or the late stage which is called tertiary syphilis. This latent stage, as we knew, can last for years. And the numbers tell us that about 15 to 30% of people who were infected with syphilis and they do not have any treatment, then they will develop tertiary syphilis complications. Some other symptoms can include, as we know, those hair loss, muscle aches, and as we knew, they can go and go back. And as the disease continues in the late stages, this disease may damage all of the parts of our body or our systems, as the brain, nerves, eyes, heart, blood vessels, liver, bones, and joints. And as we knew, it can be even life-threatening. Talking about the brain, syphilis we know can include some signs or symptoms such as headache, stroke, meningitis, hearing loss, visual problems including blindness, even dementia, and we can also lose or have a pain on the temperature sensations. Men may also experience impotence, and we might also find a bladder incontinence. At any stage, the neurosyphilis can spread and cause damage to the brain and the nervous system, and as we said, on the eye as well. Talking about the heart, then we might include this aneurysm and inflammation of the aorta and some other blood vessels, and also the valves of the heart can be also injured. When we talk about this tertiary syphilis, we know these bumps that can develop on the skin or bones or liver or any other organ in this late stage of syphilis, which is really, really hard and can be in this part very painful. We must also be aware that syphilis can be transmitted by the pregnant woman, and as we know, we must screen all pregnant women for this disease because the congenital syphilis increases the risk of miscarriage, stillbirth, or newborn's death in the few days after birth. And we can also have symptoms like deafness, teeth deformities, and a saddle nose, where the bridge of the nose is collapsing. And as we know, we have different tests for diagnosing the syphilis. As we know, we have treponema tests, which will detect antibody for T pallidum proteins. And we also have those non-treponemal tests, which will detect antibodies detected against these lipoid-like antigens. And these both of those tests will be used to confirm whether we have the infection and if it is active or it is not. The good thing about this syphilis is that still benzathine penicillin G is the most common and the best treatment for syphilis. Uh, we must also remember that syphilis is contagious during its primary and secondary stages and not really at the early late stage. And it cannot be spread if we use the same toilet bathtub clothing, but it's a very common when we have an sexual intercourse with no protection. Uh, we must remember we are on a higher risk if we have unprotected sex, if we have several partners, multiple sexual partners, if you're a man and has sex with a man as well, or if you're a patient for HIV, and if you have HIV infection, then you may you have a higher risk for syphilis because a syphilis sore can bleed easily, and it will become an easy way the for the HIV entering into your bloodstream. There's some other sexual transmitted infections that should be searched in these kind of patients, like gonorrhea and chlamydia. So we must screen all these diseases. As so far, we don't have any vaccine for syphilis, and the only way to prevent or spread syphilis it's the having responsibly sexual intercourse or even be monogamous, and we must also use protection. Just remember, any sore that we present in our body will be a way to get the infection. Okay, now talking about this Leopold's maneuver, as we remember, this is the to begin with. Just remember that the range for a full-term baby to be born will be as early as 37 weeks of pregnancy and as late as 42 weeks. Before the 38th week of pregnancy, we think about early term. If it's after 42 weeks, then it will be post-term. A full term will be around 40 weeks, and the late term 41 to 41 and 6 days. Just always remember the morning sickness or nausea and vomiting occurs not only in the morning. Pregnant women that are suffering from morning sickness can feel nauseous or vomiting all day long or even at night. Just remember this. The Leopold's maneuver, it's those maneuvers that are used to determine the position, presentation, and engagement of the fetus in the uterus. As we know, position, presentation, and engagement. And this is a systematic way to determine how is the position of a fetus inside the uterus, and they can help us to decide whether our delivery will be on the natural way or could be through a surgery. These Leopold's maneuver are named after this gynecologist called Christian Gernot Leopold. Okay, so as we will know, this is the position of the babies in the womb, which is uterus as well. We can look at the bridge presentation or pelvic presentation, and the regular presentation will be the head pointing down. We can also think about the lie of the baby. If it is longitudinal, we will say it is a vertex presentation. If the baby is buttock, it's on the or on the entrance of the vagina, then we call it bridge presentation. And if it's on the left to right, we call it transverse or shoulder presentation. The engagement talks about those the presentation of the baby, that it's pointing to the vagina. And quickening is when we set the feeling that the baby is moving. And the baby blues is what we call postpartum depression. Just to remember, bridge position is the when the parts of the baby, it's buttocks or the feet. And well, the steps for the Leopold's maneuver, it's step one, the top of the uterus or fundus is filled. We are palpating and establishing which is the end of the fetus. We're looking for the fetal pulse, which is in the upper part of the uterus. If the head it's up in the upper or in the presentation near the vagina, then we will call it bridge or buttocks, and that will be a vertical lie. If otherwise, we can also the presentation in the transverse lie. The fetal lie refers to the relationship between the long axis of the fetus respecting to the long axis of the mother. These possibilities include a longitudinal lie, transverse lie, and sometimes an oblique lie. It's this fetal presentation. It's a reference for which part of the fetus it's overlying the maternal pelvic inlet, and as we said, is helping us to determine whether the baby will be delivered in a natural way or it will need any surgery. Okay, step two, we know we must make some pressure to the sides of the abdomen, and then we might establish where the spine and extremities or small parts of the baby are located. The third step, we're using our thumb and fingers on the lower abdomen, just trying to feel if the baby is already engaged. If it is not, then we'll find the baby will be still moving. The fourth step for Lopul's maneuver, then we are facing the maternal feet, and in each hands we are applying a deep pressure directing from the axis of the pelvic outlet. If the head is presented, then one hand is arrested sooner than the other by the rounder body because it's the cephalic prominence, and the other hand descends deeply into the pelvis. We say that if the cephalic prominence is on the same side as the small parts, then the fetus is in vertex presentation. But when we call it's the cephalic prominence, it's on the same side as the back, then the head is extended and then the fetus is in a face presentation. Another topic that we will talk is the link between lupus and arthritis. We know these both arthritis and lupus may develop joint pain. Doctors will call it arthralgia. And as we know, lupus, it's a chronic autoimmune condition characterized by the overactive immune system, which has mistakenly attacked healthy parts of the body. It can impact, as we say, bones and joints. It affects around 1.5 million Americans. And the age for the presentations are mostly in women, which are age 15 to 44. Some of them will have only mild symptoms, but most of them can really have a very severe problems. Systematic lupus erythematosus accounts for around 70% of the lupus cases, which is makes it the most common. And most of the areas that impacts include those mucous membranes, internal organs such as kidneys, as we said, bones and joints, the blood, and the brain. Talking about arthritis, we know arthritis erodes the tissue in the joints that help us to scrap against each other. This friction creates inflammation, and the pain and swelling in the joints eventually will restrict their mobility. As we know, this is a chronic and continuous inflammation in the joints, and as we knew, this tends to worsen over time and can even making us a permanent joint damage. It affects about 54.4 million Americans, and it typically begins to develop in people older than 45 years. We have two common types of arthritis, which are rheumatoid arthritis and osteoarthritis. Rheumatoid arthritis is an autoimmune disease that occurs when the immune system mistakenly attacks the healthy tissue in the joints. And osteoarthritis is the protective tissues in the joints are slowly degraded by wear and tear. As we know, in osteoarthritis, the level of chronic inflammation is much lower than in rheumatoid arthritis. Talking about lupus, as we know, lupus causes widespread inflammation throughout the body, including, as we say, the joints. By the time it can develop even arthritis or arthralgia with several other symptoms, such as skin rashes and fatigue. Talking about rheumatoid arthritis, we know that a small account of people that has lupus will have a very severe joint involvement, and it looks like rheumatoid arthritis, and this complication has been referred to as lupus. Okay, some of the major difference between rheumatoid arthritis and arthritis are caused by lupus are that when we talk about lupus, this is not as erosive as rheumatoid arthritis can be. It's much less severe, and the primary joints that are affected are different. They usually affect hands, knees, shoulders, elbows, and feet. Sometimes we will use those imaging tests like X-ray, ultrasound, or CT scan, or even MRI scan to find out if this joint erosion are presenting this damage. Then we must have our medical history for every patient and also make the very good physical exam. We will be looking for signs of inflammation and reductions of the range of motions for affected joints. We can also have the SRD or seed rate or CRP or C-reactive protein laboratory test that will help us to measure the inflammation rate, follow this disease, and support the evidence of a flare. So the CRP will help us for the following of the illness and the looking for those flares. As we know, CRP it's not really specific, but in this illness help us a lot. The treatment for this arthritis or lupus are leading to be or are looking for reduce the symptoms and also are protecting further damage to the joints and of course improve the quality of life of a person. They will include medication and also lifestyle changes. And sometimes some patient will even need some surgery to correct all the damage or for even preventing further changes. We may use drugs such as the anti-inflammatory drugs or NSAIDs, non-steroidals, or those disease-modifying anti-rheumatic drugs. We might also use hydroxychloroquine and some biologics. The physical therapy is very important because it's a part of, or it helps us to keep the joints healthy, and they are preventing us further damage or helping for the mobility of those joints. The physical therapy involves some stretches and exercises, and they should be supervised by a physiotherapist. And as we said, it's just to prevent further damage. And as we said, increase the mobility of the joints. There are some exercises that can also help us, like stretching and bending the wrist regularly, making the circulation blood flow, improving the flexibility and the range of motion. We have also the chance to squeeze our a ball every day, so the tendons will be active and helping of the hand muscles. Also, placing the hands palm up on the table, flipping them palm down, and over will make stronger and more flexibility on the wrist. And we can also use some other exercises such as swimming, because when we swim, the water is supporting the weight of our body, and we are having less pressure on the joints. And we may also use some exercises such as Tai Chi and yoga and walking, because this is a low impact exercise and they can help us. Our last topic is talking about this green stick fracture. As we saw in the class, this is not a green stick fracture, but we show this x-ray to explain the difference. We said that when we have a child or a person with a green stick fracture, we must think about the mechanism of the injury, and we must think about the location, specifically where it have in all around the bone where it's the injury, if there's any soft tissue involvement, and of course we have to take care of the neurovascular status. We also must think about the joints below and above the site of the fracture, for looking for those occult fractures or even for multiple fractures. The treatments that are included in a green stick fracture include the splinting, which is only a part of immobilizing the fracture, or the cast immobilization, which is a complete casting. And of course, it's very important the orthopedic follow-up, because if we do not properly immobilize this fracture, then we might have the risk of a refracture or even a complete fracture, or the displacement of the same. As we knew, most of the time the cast immobilization is the most common, but we can also use the splinting if these fractures are not are very small, or the angulation is really small. This the time for the casting, it could be approximately 6 weeks. And of course, if we have proximal fractures, then we will need a closer orthopedic follow-up. When we talk about these green stick fractures, we know that we have a decreased range of motion. We might have experience pain when we touch the area, and we might also find ecchymosis, edema, or even if it is displaced, we might find more pain when we try to move it. We must look, as we said, about the soft tissue if we find out some abrasion or any laceration. And of course, as we said, looking for signs of the injury to the neurovascular bundle. What will be the goal for this treatment? It's to avoid the displacement of the risk of a refracture of our bone. As we said, if we do not immobilized properly, we are on a higher risk for these two conditions. Okay, and what are the causes? Or what is the definition for a green streak fracture? As we say, it's occurs because in children they have a very flexible bones, and as we know, this is a partial or incomplete thickness fracture because only the cortex will be broken in only one part and the other side will be totally complete. So it's only one side of the bone. The other will remain uninterrupted on the other side. As we said, in children, because they have an increased compliance, these bones have more bowing and bending injuries under a stress that an adult will experience. Adult bones are like more fragile and they can break totally in both sides of the periosteum. As we know, these kind of fracture patterns include green stick, torus, and spiral injuries, and all those injuries are examples of bending injuries more than full thickness cortical breaks. These green stick fractures are theorized to occur because in children the cartilage it's only calcified and it increased the radio of the collagen matrix with more immature cross links and a higher immature mature cross link radio. Therefore, before these bones are ossificated, most of this pediatric bone will be just calcified cartilage, which is very complete, very flexible compared to the bones of an adult. So we said that these fractures occur because this increased radio of collagen matrix and more immature cross links with a higher immature mature cross link radio. Just to repeat. Okay. We knew that malnutrition, specifically vitamin D deficiency, increases the risk of green streak fractures of the long bones after a trauma. Talking about the mechanism of the fracture, we know that bracing a fall on a push means that we are falling down and protecting our arms. We are outstretching our arms to protect our hands, so they will result in a fractures for the upper extremities. As we know, most of the time, these fractures occurs in pediatric age, but we might also find the green streak fractures in adults. And as we know, just to make the difference between green streak fractures and Salter-Harvey fractures, we must remember that when these fractures involves not only the diaphysis and metaphysis, but also the physis, then we classify this fracture as Salter-Harris, that it's involving the physis. Again, as we said, as a result of the thickening and strength of the periosteum in children, this will decrease the chance of open fractures and the fracture displacement, because as we knew, pediatric bones are very complex and very flexible. And also in the pediatric age, the periosteum is more active, it's thicker and stronger. So it really decreases the chance of these fractures. And as we know, these green streak fractures can also occur in the jaw and nose, not only in long bones. And we knew that condylar fractures are the most common pediatric mandibular fractures.